And now I'd like to introduce our speaker. He will be talking about knee issues. Dr. Ismar Dizdarevic is an orthopedic surgeon with the Ridgewood Orthopedic Group in Ridgewood. Welcome, Dr. Dizdarevic, and thank you for the presentation this evening.
Thank you, Sue, and thank you all for being here. I understand it's a little bit later in the evening, and I'm sure everybody's families are trying to kind of get their attention. But I do think we have an interesting talk to share with you. And while surgery in general tends to be an individual endeavor in some ways. Something like a total joint program is involved many people, and it took a long time to get to a point where we can do these surgeries efficiently, safely, and really have a nice pathway for patients to recover through and ultimately improve through. So and it's not just the doctors, it's many nurses, it's many reps, it's many family members, it's many staff from both my office as well as the hospital. People have devoted really a great deal of time, and what you hear today is really just a reflection of all the great work that everybody here has contributed to. So without any further ado, I would like to introduce myself. My name is Ismar Dizdarevic. It is a very common North Jersey name, despite it looking so strange. And to kind of break the ice, I had a situation happen when I was leaving my fellowship in joint replacement surgery in Chicago. And as I was leaving, one of the gentlemen that was kind of at the airport with me, kind of saw my name because I was wearing I think my scrubs. I was just trying to, I was flying home, and they said, "Oh, that's a very interesting name you have. Is it Turkish?" And at the time, I had said, "Actually, it's not. It's Bosnian, but my family has obviously Turkish heritage." And because of that, he said, "Well, of course you do. Your name means something very specific, and I just want to share with you guys what that name means." And that really means, all right, let's see if this works. There we go. So the Turkish word for knee is diz. And for just about all my training, I've been Dr. Diz, just from the difficulty of people pronouncing the name. And for many years, I had a good friend named Mike Bonensteel, and he was an orthopedist. And I just looked at Mike and I said, some people are just born with just the right name. And here all along, just a different language, I was sharing a similar gift. So otherwise, I don't know I hope you guys can actually see me, but if you don't, I tried to search a picture of myself, and all of these people showed up, and only a few of these people are the real Ismar Dizdarevic. So my whole group is right down here. That is the Ridgewood Orthopedic Group. This was me 10 years ago. This is me now. And all of these imposters, I know who some of these are. This is like the Greisberg from Columbia, but none of them are actually the real Ismar Dizdarevic. So beware. Otherwise, a quick kind of agenda outlook for what we're going to talk about. Obviously, we're going to speak about knee replacements. I will try to bring you up to date to where we are currently at, and where I hope to bring the surgeries to. There's going to be a little bit of a background because you kind of have to get a frame of reference for why there's such kind of a push for technology and kind of outpatient surgeries and smaller incisions and faster recovery. There's obviously always going to be a geopolitical kind of climate that we're faced, that we respond to. And then the rest of the talk will kind of focus on what it means to have outpatient surgery, how we got there, the pain management that has allowed us to really push the limits of like how we can safely discharge patients home to a safer kind of care environment. The different surgical options that are involved when it comes to knee surgery or end-stage knee surgery, knee surgery that is kind of come to the point of replacements. Obviously, the improvements in technology that have allowed us to come here, and then finally, the improvements in the actual surgical techniques. And finally, I'll just close off with some of the post-operative rehab goals that we have and how those goals impact care long-term. So the background of joint replacements worldwide, but really in America, is that we have some people have referred to it as a tsunami of the need for joint replacements coming our way. And, this is only in part to like kind of the baby boomers aging to that level. It also has to do with activity levels that people would like to uh, hold on to as we kind of enter, older years. But also from the large amount of orthopedic surgery that has happened to essentially, everybody from teens onward. I think most people have friends or family who have had some level of an orthopedic surgery, whether it's as small as a knee scope, to an ACL, to, obviously more complex reconstructions. But most surgeries, unfortunately, while they tend to kick the can down the road and they cure the problem in the immediate, they tend to unravel kind of a chain of a chain of events that will eventually lead to what we call the degenerating joint, which is unfortunately a disease that does not have a cure. And while we like to say that we are curing osteoarthritis with joint replacements, we're really not. We're curing the end damage, the end organ damage, but obviously arthritis, still ends up winning that race. So, as you can see right here, somewhere between, and I have my own personal opinion as to what happened, but the growth of joint replacements, through the early 2000s and maybe even to like the later 2010s, remained fairly constant, especially for knee replacements. And then all of a sudden it began to kind of accelerate. And the predictions that we have today is that we may even be doubling those numbers over the next decade. And what I really believe is happening is that pickleball came to be right around here. And once pickleball came to be, then all of a sudden, people's knees started to fall apart. And, I encourage everybody to go back to playing tennis and avoid pickleball at all costs. So, with that said, the kind of the 10,000-foot view is that with this significant increase in volume, right, the payment systems had to change. Joint replacements is the number one expenditure for Medicare, and I'm sure for most insurance companies. And at the current rate, the amount of money that will be allocated, that would be needed to be allocated toward joint replacement would essentially, bankrupt the fund completely. So the models have changed. And in the past, the models used to be very simple. You have a surgery, you submit a bill, you get paid for X amount, what we call fee for service. That is no longer the case. Now it's what we discuss as value-based care, where essentially every single joint replacement, hip, knee, and a slew of other surgeries kind of coming down the pike, and I'm sure all the surgeries eventually will kind of come with a specific monetary amount, and that will include your entire episode of care, from the surgery to the implants to the the post-operative visits to the X-rays to the rehab. And not only that, but the way that Medicare structures it is that any complication, not even just related to the joint replacement, you could have a gallbladder that decides it wants to start acting up on you, falls within that bundle. So what we call a bundle, which essentially incentivizes surgeons and the family medicine doctors to really make sure that patients are optimized before they go for surgery. And ultimately, this is thought to down the line be able to be one of the ways that we can, save money for the system. And obviously that will trickle down to everybody else. So the model changing has been a really, really big driver for how we deliver these surgeries. We used to, at some point, I just want to show you, in the past, when I started my orthopedic training, it was very, very common. This was in New York City at the time. So New York kind of plays a very special role because everybody seems to live in like on the 5th floor of a walk-up building, and discharges were very complicated. But most people, it wasn't unusual if people would spend 5 to 7 days in the hospital after having a joint replacement. At the current volume of surgeries, there is no way that hospitals will ever have enough room to kind of house that kind of volume, much less allocated to any of the other subspecialties. So as time went on, the length of stay got less. Obviously, surgeries got better. We were offering it to younger patients who were then able to kind of mobilize a little bit sooner and get home. And then up in this is actually supposed to say 2010s, the gold standard was really like 3 days. And if you could discharge somebody within 3 days, whether it was to a rehab center or to home, I mean, everybody was high-fiving at the end of that day. But if somebody stayed in the hospital for 3 days, today that would be, considered essentially, a loss, not only for the hospital, but for the surgeon and potentially for the patient as well, because, obviously risks for a number of ways kind of increase the longer you spend in the hospital. So, in 2018, and I'll kind of just skip this, and this was essentially the projection in 2019. They said that total joint replacements will go somewhere from about 10% outpatient potential to needing to be somewhere between 30 to 40% outpatient. And those were the numbers that were essentially deemed to be requirements. And if they were not able to be reached, then obviously that there would be a huge rationing of care that would take place, because you would not be able to accommodate the volume. Obviously, partly because of the facilities, but partly because of the number of surgeons that would be doing these procedures. So today's length of stay is the gold standard is that it is an outpatient surgery. And this is something that's not, a decision that was made, by Valley Hospital or by any hospital. It was essentially made by Medicare and the Centers for Medicare Services, CMS. And in 2018, unbeknownst to many of the surgeons, because we always felt that the hip replacements were easier to send to discharge home and safer, Medicare actually approved a total knee replacement to come off of what's called the inpatient only list, which means that you were able to now do it at an outpatient either center, or you were able to discharge a patient same day. And in fact, that was actually the expectation. And then a couple of years later, the same principle arose and brought total hip replacements into what's called the outpatient or not inpatient only lists. And with that began kind of like the modern age of joint replacements and all of these kind of minimally invasive techniques that we try to utilize, because obviously the less trauma that we can cause in our pursuit of a functioning joint, the easier it is to go home. So essentially, if you are healthy and if there are no complications following your surgery, you are able to go home. There's very, very few things that can happen. It is very safe. Short of incisional drainage, there's really not much that the hospital itself would provide in that acute period. Obviously, mobilization is important and, pain management is important. But that is something that we were able to essentially figure out on the pathway to discharge. So what we call same-day joints or outpatient joint replacements is now essentially the gold standard. And according to, and this isn't just me, this is multiple studies across globally essentially have deemed it to be a safe surgery. Looking at actual, complication rates, readmission rates, reoperation rates, patient satisfaction rates, actually, at 90 days, there's no difference. And the patient satisfaction rates are actually a little bit higher when people can go home, because essentially they feel that they are more in control of their environment, as opposed to being in a hospital where you're kind of at the beck and call of who's around. And obviously, worst scenarios, which is, the discharges to potentially to rehab centers. Other than that, and this is what I wanted to mention, the satisfaction rates, and within our hospital, they're actually a little bit higher too, because we do keep these scores. They tend to be extremely high for discharges at home. So people are doing quite well and they're happy to do it. So, as much as I'd like to take the credit for that kind of, push or that kind of a road opening for patient discharge, it has nothing to do with or has very little to do with what I do. In fact, it's actually anesthesia and our multimodal kind of pain pathways that have allowed this to really take place. Most joint replacements, especially knees, if they are well balanced and they are done by obviously, joint, trained physicians or surgeons who have done this for a long time, they allow for mobilization right away. They allow for us to walk right away. They allow us to bend our knee right away. They can bear weight. They shouldn't buckle. It is what we call a weight-bearing surgery. But unless you can control the pain, it doesn't matter how good of a job you did. The person will not be able to stand up because causing essentially upwards of 7 fractures in a knee will result in a tremendous amount of pain. And at least we've found that if we're able to provide certain multimodal, pain management options, we can control this, quite well. So the traditional kind of pain control used to be something that we refer to as reactive, pain control. I hit myself, I have pain, I'm going to put ice on it, I'm going to, take a medication, I'm going to elevate, I'm going to rest. That is still in response to an injury that already took place. And for most, body systems, we are evolutionarily, programmed to respond to pain because it is such an important aspect of sensing our environment. So once the injury takes place, it's very, very hard to kind of battle back from it. And, for this reason, we relied often on opioid medications, whether it's oral medications or IV medications. And obviously, most people at this stage are fully aware of the damage that is caused. And I would say that, orthopedic surgeons were kind of at the crux of that process. Obviously, there was a lot of pharmaceutical kind of intervention, but orthopedic surgeons, essentially would this is the best medication that we had. So if you had an orthopedic surgery, it's a painful surgery. You need something, and we would prescribe these medications. And personally speaking, my first narcotic ever that I took in my life was after my ACL reconstruction. So, and I was 20 at the time. I was in medical school, or 21 at the time. I just started medical school. So, it's something that it is important to kind of move away from. I think these medications are still very, very important in the acute phase, but we are slowly moving away from them and actually relying on these types of medication, what we call multimodal pain pathways, not utilizing any single pathway, but a multitude of angles where we can intervene on the pain pathway. So Tylenol, very underrated, and it probably by itself does not do much. Most people will tell you, oh, if I take Tylenol, it doesn't really help my knee pain too often. Most people are not taking it at the right dose, as we like to follow directions, and over-the-counter doses in general are over-the-counter doses for a reason. It's so that the level of toxicity is very low and that companies are allowed to sell it over the counter. But Tylenol works very well, and it works very well in conjunction to NSAIDs. It actually potentiates and it synergizes with a lot of other medications, and it makes those medications work better. So gabapentinoids are they should have a little bit of an asterisk there because they do work, and these are medications that work on nerves. It's just that oftentimes the amount of the medication that we currently need to take is so high that sometimes sleepiness is a side effect. And obviously after a joint replacement, you don't want to be tired, drowsy, sleepy for risk of falls. But NSAIDs are basically the other kind of pillar of the multimodal pathway. NSAIDs could be as simple as ibuprofen, Aleve, to prescription strength medications like Celebrex, Mobix, and diclofenac is typically what we use in our office. And then, of course, longer acting opioids as opposed to immediate acting opioids. The addictive potential of opioids is to a large degree linked to the rate of absorption into our bloodstream and eventually to our brain. So if we're able to provide more longer acting opioids, that spike is not so high, and the benefit of the actual narcotic is still experienced. And then, of course, and this kind of constitutes what we call a proactive approach. Then what happens is you can't just give somebody a little bit of Celebrex and then ask them to lay down and, open up their knee with a knife. So we do rely on anesthesia, but no longer is it really relying on general anesthesia where we actually have to sedate the patient to the point of not feeling, or feeling pain, but not reacting to the pain. But oftentimes we rely on things called regional blocks. So this is no different than your dentist, blocking a nerve in your mouth. We just do it at a much more upstream level. Spinals will block it at the exit point of the nerves from our spine. Adductor canal blocks will actually block it around the area of some of our nerves peripherally. And then, of course, it matters what I do in my surgery, because the more that's fine. The more that I cause trauma, the larger my incisions, the more damage I cause in my approach. Obviously, the more swelling is experienced, the more stiffness is found, the more bleeding potentially, and then all of these multimodal medications can no longer suppress the wave essentially that's coming in, and you want it to be a little blip and not necessarily a large tsunami of pain that's coming down the line. And this is what really the crux of my talk is about, this idea of less invasive surgery. And we love to talk about different types of hip approaches and how some can be more minimally invasive and constitute less pain in the early, on average, in the early postoperative period. But very few people talk about it for knees, even though, like I said before, most surgeons were confused as to why Medicare took the total knees off the inpatient list first, as they were clearly the bigger problem, for discharge and for getting people away from the hospitals. Knee replacements, talk to anybody, are still more painful. They require more therapy. They require more swelling. They require more medications than a hip replacement. And unfortunately, we spent all this time speaking about hip replacement approaches and how we can minimize and using robotics, but very little time was spent actually talking about joint replacements. So none of these processes just occur. They evolve. And we've been doing joint replacements for years. I actually just took a tour of the new Valley Hospital, and I saw that in 1970, Dr. Pizzuro, Joseph Pizzuro, my partner's father, now late father, did his first hip replacements in 1970, right? And that means people before them were doing, hip and knee replacements as well. It's just that today we've really offered it to people that are much younger. In the past, you would really have to be at the point of not walking, and even then you'd have to be an excellent candidate to even be considered a candidate for a knee replacement. Today, as soon as the functional loss starts to be more than just let me take a little bit of medication, the potential for joint replacements is already on the table. So I meant to kind of just give everybody a little heads up. So this is typically how a joint replacement is done. This is a conventional knee replacement approach. And what you'll see is, and this is what I refer to as what we call MIS surgery, maximally invasive surgery, right? Not minimally invasive, but this is maximally invasive. And when you rely on things like, so right over here, this is a tibial cutting jig that's nothing more than a right angle on a rod that has two pins that allow it to kind of fix it on the tibial, on the bottom bone in our body. This is how most surgeons to this day will still make all of our cuts. And to do this reproducibly well, you have to see the whole joint surface, right? You have to be able to take the kneecap and the patellar tendon and the quad tendon and completely sublux it away from where it should be. It should be sitting right in the middle of this. So just imagine, for this kneecap to end up on the way side of your knee, that quad muscle and that quad tendon has to be cut 4 to 5 inches up that muscle. The tibia has to be subluxed to the front of the knee, which means essentially a lot of the ligamentous structures tend to be ripped or they have to be released. We then oftentimes relied on, cutting some of the native ligaments, and we're then tasked with a true reconstruction surgery of a knee. This is not how it's done for a lot of people, especially at Valley, where most, if not all, actually all the surgeons use robotics. You do not have to create necessarily the same types of incisions as you had to in the past. Coupled with that, the idea of partially replacing arthritic joints has really taken off. And I would say over the last 10 years, partial knee replacements are the most satisfying surgery, not only for the surgeon to do, but for the patients to experience, because they can have a very quick recovery through a very, very small deliberate incision that allows for a much quicker rehab. And while a partial knee replacement was a more complicated surgery because of the limitations in the exposure to the knee, but also how you position the implants, today's use of robotics is really made it the gold standard. Even our kind of academic physicians have really gone out on the limb and said, anybody doing a partial knee replacement today should be doing it with a robot, because the complication rates are less, the revision rates are less, the success of the surgery is much, much higher. So the idea is, as we find arthritis, symptomatic arthritis in the earlier stages, before it really starts to encompass the majority of the cartilage in the knee, we are able to intervene. And some people believe maybe even halt some of the progression of osteoarthritis across to the kneecap, across to the opposite compartments. And these, surgeries, I'll show you, kind of come in a variety of fashions, right? They could be medial partial knee replacements, lateral, so on the outside of your knee. They could be patellofemoral. Some people have even tried doing bicomp for maybe osteoarthritis that has already begun to progress. They can now replace two segments of the knee without sacrificing the ACL and without sacrificing a healthy side of the joint. Traditionally, 5% of people were deemed to be appropriate candidates for partial knee replacements. Newer data says that maybe up to even 30% of patients, even having a little bit of arthritis behind your kneecap, does not necessarily mean that you should not have a partial knee replacement, because this may not constitute what we call symptomatic arthritis, and people can then have more of their own body in place for a longer period of time. Patellofemoral joint replacement. This is a patient of mine where you can see that they probably do have a little bit of lateral compartment, wear, because they have a small little bone spur, but they still did remarkably well with just a partial knee replacement with a much, much quicker recovery. This is another patient of mine who came in for, as you can see, loss of cartilage only on the inside part of the knee. The outside part of the knee still shows good space, which essentially means you have a healthy joint. Following her surgery, there was actually a small fall that happened at home. And it's hard to see, but there's actually a small compression fracture right on the side. As you can see here, there's no bone spurs. And here it makes it seem like a small bone spur formed. These x-rays were only taken 3 weeks apart. So somebody did not develop osteoarthritis within 3 weeks. What happened is when the knee buckled and the patient fell, she actually sustained a compression fracture on the lateral side. So instead of replacing the whole knee, which is essentially in the past what you would have to do, we were able to simply replace the other contralateral side, and the patient still has a functioning ACL and a functioning patellofemoral space, which is the kneecap and behind it. So, this is just a kind of a quick kind of, sorry, I just want to show you. I don't know if it's going to play. Let's see. There it goes. So you can see that, for a partial knee to occur, you really only need to have a little bit of exposure to the side of the patellar tendon. And oftentimes you're able to do this very, very efficiently without cutting the quad tendon, which is, as you can see, is draped over the kneecap, because ends up being more of a resurfacing operation. So you don't need a large exposure. You can essentially leave most of the ligaments intact. And you can basically perform what's a glorified dental procedure of a capping, a crown placed over the end of the bone, which now has a piece of plastic that acts like the new joint surface. The problem is it's very hard to do total knee replacements with these kinds of approaches. And the evolution of what I now refer to as quad sparing knees, knee replacements that are truly minimally invasive, surgeries that don't have to cut any of your muscle, they don't have to remove your PCL, they don't have to over-release or tear any of the stabilizing ligaments to the knee, are really an option now. And because of surgeries like the partial knee replacement, surgeons have gotten more comfortable performing these surgeries with a very, very deliberate and minimal approach. So this is what a partial knee incision compared to the other one might be. And the idea is that when you talk about truly minimally invasive surgery, it's kind of a catch-all term. It doesn't, for a lot of people, it doesn't mean much. So I always like to explain to people that minimally invasive surgery is kind of the goal, right? Ultimately, the goal would be non-invasive surgeries, right? Non-invasive healing techniques. But minimally invasive surgeries is almost like the path and the goal that we're trying to achieve. And really the way I like to describe, what I do in my practice is that these are quad sparing knee replacements. So if you look at a traditional knee replacement, the incision is large, it's longitudinal, it goes right down the middle of your knee, it cuts the quad tendon and oftentimes cuts into the quad muscle. As opposed to what we call a quad sparing knee replacement, which is a smaller blue line that you see there. What patients see is just a smaller incision on their skin, but really what's happening is that there's a smaller dissection field underneath the skin, and which essentially preserves your muscle. And by staying underneath that medial side of the muscle, which is the most important part of your quadriceps muscle, we're able to preserve the function. And the hope is down the line, if we can do these successfully, really improve the speed of healing. And some of the stories that you would hear that it took a year for my knee replacement to stop hurting now can be hopefully achieved in much, much shorter periods of time. This is what a traditional knee replacement is. The incision has to be long because you need to remove that kneecap out of the equation. This is what a minimally invasive incision is. So this is actually a partial knee. This is a total knee. So you can see that it's not very, very different in size. And, the reason it's a problem, and this will kind of show, is when you're resurfacing just the inside part of the knee, there's not really a lot of mobilization of tissue. But if I'm trying to put in and make cuts on the opposite side of the knee to where the kneecap is, you can see that I would have to remove essentially that patella out of the equation in order to do so, or at least in the past you would have to. And the total knee replacement essentially functions very similar to a partial knee replacement, but now the whole end of the bone is resurfaced with an implant that looks very similar to our native anatomy. And then again, the piece of plastic, which we call the liner or the bearing surface, acts like your new mobile joint. And that's essentially what a total knee replacement is. So the idea of what we call quad sparing knee replacements or minimally invasive knee replacements is that it does encompass a very deliberate incision because but it's not the crux of the operation. I like to make a small incision because I think it offers a buy-in to the patient. They see that they have had a different approach, a different surgery, maybe can prevent some of the wound healing issues or the speed of healing if done correctly. But the idea really comes down to a minimal soft tissue dissection, which means very, very specific releases of ligaments. In the past, we used to essentially just release all the ligaments and then say, okay, well, what are we left with? Let's now utilize implants to see if we can reconstruct the knee. And if we can't, then we have to use better implants. And a lot of the technology in the early phases of the knee replacements constituted what we consider the idea of constraint. If I release a ligament and I have over-released it or potentially the ligament tore, now I have to use the implants to take that same function and give it back to the knee. There's always a cost to these things. Implants tend to wear sooner when this happens. There tends to be more complications. There tends to be potential for a more complicated revision surgery if there ever needs to be. The implants tend to be larger. Infection rates tend to be, higher. So there's a number of reasons why you're trying to really minimize that soft tissue sleeve. There is no patellar eversion, meaning that the kneecap is just kind of pushed to the side. It's not flipped around and completely removed from the equation. You do not have to dislocate the tibia, meaning you don't have to shift the tibia so far forward that some of those ligamentous structures tear. You obviously have to, spare the quadriceps tendon, at least the tendon, and likely even you need to do that with the muscle as well. Do not remove the suprapatellar pouch. Save the ligaments or whichever ligaments you can, what we call cruciate retaining surgeries. The goal eventually is to limit even the use of tourniquets, and then of course have very deliberate skin closures that seal the system in place. So this is a patient of mine who had a total knee replacement. So it looks very similar to the partial knee replacement picture, but this is actually a total knee replacement. So you can see if you kind of look at the red kind of muscle, you can see that it covers half of the femur. It is fully attached to the kneecap. The kneecap is still centered in the knee. And the window that we have to work is just essentially it's the same window as we do for partial knee replacements. And, being able to do this does have the potential to increase quad strength, decrease muscle damage. And the goal is that once we get better at these types of techniques, it will improve function, decrease recovery time, increase the rate of reciprocal stair climbing, and a number of factors that are starting to kind of, to be talked about today. But what I'm talking about is not new, right? Good surgeons have developed these techniques years ago. I mean, you're talking about 20 years ago, some of these studies that initially came out and said that these, minimally invasive subvastus types of approaches, quad sparing types of approaches show a benefit. And, it took very, very dedicated, very skilled surgeons to be able to do these things. And the initial studies were very positive, and with any, positive studies, the adoption of such a procedure begins to take hold across the country. Unfortunately, if we're not teaching these types of approaches well, and people who are untrained in it begin to utilize them, then all of a sudden those studies start to kind of bear the brunt of these kind of inadequacies in not only surgical technique, but also an understanding of how these surgeries should be done. And for the next, probably, I would say decade, most of the studies that came out to talk about, minimally invasive knee replacements, subvastus knee replacements were very, very negative. And they actually focused on a lot of complications. And I always like to remind people, the surgery was good. The surgeons were not doing a good job at performing the surgery. So when the vast majority of the orthopedic community begins doing things because they see it or they hear about it, it doesn't mean that it's safe to do. And it really requires a specific type of training. And for that decade, all of these studies came out and said, not only is minimally invasive surgery providing no real benefit, but it's actually causing more damage, right? People had terrible wound complications because skin was stretched in ways that it shouldn't have been stretched. Because the visualization and retraction of the tissue was very difficult, people would have avulsions, which are really catastrophic scenarios to happen with the knee replacements, where patellar tendons, quad tendons, vessel injury, bone fractures, malalignment, cement that was, retained in the knee, were all starting to kind of show up in literature as real, potential problems surrounding minimally invasive surgery. And ultimately, it became very, very hard to teach. And if something is hard to teach, it's hard to adopt. And X-rays began to look like this, as opposed to very, very clean. You can see that the tibia is tilted. It's actually sitting up on the one side. There's retained cement that's left in the knee. This patient, I actually believe, had a quad tendon rupture, because if you see, the kneecap is very, very low on the face of that knee replacement. It should be much higher up. So this, essentially, put an end to minimally invasive surgery, and something that came out to be very, very good and beneficial in its appropriate use became very dangerous for the average surgeon. And from 2016, essentially, people abandoned it. But there was no such thing as, telling an orthopedic surgeon that this is, not doable. And oftentimes and this is really just kind of corny, I just didn't have a better way. I didn't want a hand sticking out of the ground. But the idea that, minimally invasive surgery really made a resurrection as our technology caught up to our desires, so to speak. And this is really something that I was critical to my growth as a surgeon and me being able to perform these surgeries very, very safely, is the idea of robotics. And we're very, very lucky that Valley Hospital was one of the first, it may have been the first hospital in New Jersey to have robotics, to have the Mako robot, not only for partial knees, but total knees and total hips. And like I said before, we've been using this technology now for 6 years, and it is ubiquitous in our hospital. There's not a single surgeon that doesn't use it for primary joint replacements. It is wonderful because it relies on high resolution imaging, CT scans, as opposed to X-rays. Obviously, the more information that I have, the more of a appropriate decision I can make for that individual patient. And really the way it works is that I'm no longer just eyeballing my surgery. I'm no longer using just right angle cuts to try to make the knee fit a generic, bony contour. I'm now utilizing a very, very specific patient-tailored approach. And not only when it comes to the actual positioning and the sizing of the implants, which is what you see here in kind of the 6 planes, but, and this is kind of how the X-rays, tend to all look. They look very, very symmetric. They're well balanced. But it actually provides what we call the kinematic benefit to knee replacements, how the knee moves and the amount of stiffness that the knee has, and the way that patients can achieve higher ranges of motion without necessarily relying on, people just pushing on their knees and causing pain. This also, I just want to bring to your attention, this is what we call a press fit implant. So there is no cement that's used for this implant. This is a biologic implant that, when placed appropriately, bone will grow into these implants. That's why you see these 3D printed surfaces on the back of these implants. It allows for bone to interdigitate into these implants, which essentially becomes a lifelong implant. If there's a physiologic, biological connection of your bone to the implant, this is you. This is a metal version of a knee, but this is a part of you, and it's no longer just glued or bonded to the bone. So my response, to the community, and it's not just my response, there's a number of surgeons that are actually kind of like leading this charge, and thanks to the industry and Stryker, namely, we are actually building teams to start to talk about these things, to start to see, can we safely show other surgeons how to do these? And what I've always kind of come back to is, just because something didn't work once does not mean in medicine or in life that it's over, right? It means that we have to look back and we have to say, what did we learn from some of these mistakes? And the idea of visualization and the need to have these very, very large incisions where we see every single, nook and cranny of that patient's bone is no longer necessary, right? Because I have a robot that can see for me. Surgical times are also getting shorter. And some of the wound complications associated with stretching of the skin are now getting less, because I no longer have to wait for cement to heal. I don't have to guess as to how the kinematics or the motion of that patient's knee is going to behave, because I can do that in a virtual time. I can plan these surgeries before we even set stage into the operating room. X-rays no longer look, the way that X-ray looked. Partly because there is no more cement, for most people. And partly because if there's one thing the orthopedic community can agree on when it comes to robotics, and I'll tell you, it's a hot topic of debate, and, obviously time will play out the way that robotics always plays out. But the one thing that we can agree on is that our X-rays look better when we use robots. We can hit our targets more precisely. And now the question is, what is that target that we need to be hitting? Malalignment is less, loosening rates are less, and even we're beginning to see that revision rates for younger patients having press fit implants or biologic implants are starting to be less, which ultimately means that we may be creating lifelong implants, which is the ultimate goal of all orthopedic surgery. So really, MIS is now it's a melding of technology and surgical techniques. The surgical techniques being these, minimally invasive, quad sparing, muscle cutting, avoiding types of surgeries that I really have made a cornerstone of my practice, coupled with the idea of robotics, better implants, better polys, better ingrowth surfaces. It has now brought back to the table the idea of minimally invasive surgery, and I hope that it kind of flourishes from there on. And it's 7:45, so I think we hit it right on the head. I'll just run through like a really quick case just to show you the kind of what we're capable of achieving with some of these very, very complicated cases. This is a very, very valgus knee, which means a knock knee. So when you look at it from this view, you can see that it's bone on bone, but you don't have really the perception of what that means. This is what it means when somebody, and then this gentleman had a fracture from a motorcycle accident above it too, and likely led to his, degenerative changes. But I just want to, cover him. He's a very fit, very strong person. He's in the gym a lot. But if you look at that left leg, that's not a normal, look to the leg, right? And when he walks, that knee almost looks as it's about to completely snap in half. So this is a very, very complicated surgery to do. This is what his full length, bone scans look like. This would be a complicated surgery to do with manual instruments. But with robotics, knowing fully well where I have bone, what bone I can essentially have access to, how I have to position my implants, we're able to kind of come up with these plans that are much more comprehensive and have allowed not only me to learn about how the knee actually functions, but allow myself to teach other people how to do these things as well. And that's really kind of the key. And when the surgery is done, now you can see the leg is nice and straight. When you take a full length X-ray, you can see that his knee is reconstituted. You can't see because I blocked his face here, but he is smiling beyond belief in this picture because he is happy to have, essentially a knee that allows him to go back to exercise and activity. And, he will, unfortunately, and he's aware this will be coming back for the right knee very shortly. As you can see, the right knee itself is also bone on bone on the opposite side of his knee. And then the final thing, I kept using the term kinematics, and kinematics is the idea of like, how does the knee move? This is an opposite kind of like, deformity where it's very, very bowed. So this is a 17-degree, that other gentleman had a 24-degree valgus deformity. Somewhere between 3 to 7 degrees of valgus is normal. This is now the exact thing, except in the opposite direction. The knee is very bowed. 17-degree deformity is a very, very complicated thing to fix. The idea of kinematics is that I can now tell these two are stressed views. So I can tell what are his native ligament tolerances. So you can see that if I just do a small release, I can fix that varus, that bow, from 17.5 degrees to 8.5 degrees without even making a single cut, just essentially planning for how the knee is going to behave using the CT scans that were done ahead of time. So now I've already brought him in, uh, what is it, 15 or 9 degrees just by without even like relying on my implants. And now when we bring our implants into play, we can start the idea of balancing the knee. So if you look at this, these are the tensions across the knee. So these are gaps. So the tighter the knee is on the side where I need to loosen it, the tighter, the smaller that gap will be. So if I put a knee in that was 0.5 millimeter tight on the one side and 2.5 millimeters loose on the other side, that would be a very unstable knee. It would give the patient a feeling of instability. But by now adjusting in virtual time before we even get to surgery, by adjusting the positioning of the implants, I can now have those gaps balanced. And you can see now we brought him actually down to 6 degrees of varus, which I'll tell you right now, going from 17.5 degrees to 6 degrees, that person, this is their native appearance to their knee. And they will think that their knee is completely straight, even though to me on the computer, it's actually just a few degrees off. But the balance of the knee is now normal. The same thing in flexion. You can see imbalance on this side, very, very tight on the lateral side. It makes a few small adjustments, and now we have 3 and 3. And this, I hope this plays. Yeah, so this shows you now what we can do. This surgery hasn't been done yet, just so everybody's aware. This is just planning. So we can then take the knee for a range of motion, and you can see that it's actually moving the way it's supposed to. If that's how the knee was moving, that tibia was subluxed forward, that would be wrong. The center point of contact has to remain the same all throughout the range of motion. So as you see that, it always stays in that posterior third, and I can essentially plan for how the knee should move, not only how the knee should look. And this is essentially what I'm looking at when I'm performing my surgery. I'm looking at a screen, but I'm actually operating on the knee in here. And you can see a very small incision, very deliberate approach. The robot can get to angles that I cannot get to, and it can do it safely without cutting any tissue. This is our PA. She's wonderful. She's happy because she doesn't have to be pulling and ripping tissue and, kind of manipulating the knee. This is essentially the system for what we have in place. All the retractors are there. All the sensors are there. Essentially, the surgery is done in just about full extension. And at the end of the surgery, this is what 6 degrees of varus looks like. A perfectly straight knee. The knee replacement you can see is inside of the knee, or at least the trials are. Everything comes out, and we can finally implant the patient, in a very deliberate and specific way. And then this is his knee afterward. And that is it. So I think, the surgical wound and dressings, I think, are less important. We're trying to glue patients more because that seals it. Some of the occlusive dressings that are not adhesive based obviously cause less reactions to the skin. They also keep the incisions completely sterile. And then, of course, like, the therapy that's involved with it, we don't have to necessarily get into now. But, this is really what I've been using for the first 2 weeks at home, and patients come back and they tell me, what they love the most was the Romtech machine and the Rice machine. And essentially that's how they get through those first 2 weeks that are still going to be, tough for anybody. But once we, hit the outpatient therapy, mode, patients are already doing, miles better than the counterparts in their beds next to them. So that is it. I would be happy to take some questions. I think we have 10, 15 minutes.
Thank you so much. That was so interesting and thorough. And just a couple questions out of interest, if anything. Would same-day surgery and replacement, is it going to be performed in Paramus or Ridgewood? Is it mainly going to be in Paramus?
As of right now, the hospital is, my understanding is that the hospital administration is still lobbying the state to allow them to perform outpatient surgeries at the old campus. We are not allowed to do that as of right now, because the moment that the new Valley Hospital goes live, the old Valley Hospital shuts down. So only endoscopy and a couple of the imaging modalities will remain. I personally hope that I get to go back to the hospital. It's closer to my house. So that's a purely self-serving reason. But as of right now, outpatient surgeries will be done at the New Valley Hospital for the correct patients. I really have to just specify that. It doesn't mean that every single person should go home or be allowed to go home, but we have like very specific kind of criteria that we look to, and many patients, just about 30%, we expect to be sending home.
Okay. Question, I think I want to say this right. What are your views on platelet-rich plasma and stem cell injections for osteoarthritis knees, especially for stage 3 and 4?
Yeah, that's a very, very good question. I can tell you my views, and I can tell you my academy's views, right? My personal views is that there may be a benefit for lower grade osteoarthritis, because there probably is some anti-inflammatory effects that at least platelets have, or platelet-rich plasma has. But according to our academy, there's no data, right? So to use it for advanced osteoarthritis, it's really just, at this stage, it's just snake oil. When there is no data and we inject into something into the knee, while there may be no harm, these modalities are very, very expensive, right? So a PRP injection is $1,000 in most places, maybe more. Stem cell injections are somewhere between $3,000 to $6,000. It is prohibitively expensive for most people, and there's always going to be ethical considerations that you have to also think about. At that level of payment that somebody has to pay out of pocket, I would feel, morally conflicted unless I knew 100% that this will solve that problem. And I can tell you right now, as a surgeon and as a person who lives and breathes arthritis, for advanced osteoarthritis, grade 3 and 4, there is no data, and it cannot regrow cartilage the way that it's being touted. It can maybe cause a little decrease in pain from the anti-inflammatory response that the body will kind of generate, but it will not cure arthritis, and most people will end up having a joint replacement very, very shortly if they're at that stage of degeneration.
Okay, a couple questions about post-operative. Can you talk a little bit about physical therapy after a knee? And do you have a general idea of how long recovery time is?
Yeah, I have a very good idea. We are still relying on physical therapists because we are neurotic. Um, it is important to have a good relationship with a physical therapist, because what it allows for is somebody to monitor, right? Because I will see you the day of surgery, in the office for the wound check, and then at 6 weeks. But that's a big baton that I have to pass off, right? I know that now I can do these surgeries very well, well balanced, well positioned, but I still have to rely on the patient's motivation to get their motion back. Because if there's one test that will tell me how the person is doing when they come in at that 6 week mark, it's not an X-ray, it's not a CT scan, it's not an MRI, it's not a blood test, it is range of motion. If somebody comes in at 6 weeks and they show me 115 or 120 degrees of motion and above, I know that they are happy. So the idea of a knee replacement is that it's really a surgery of motion. And I am still unwilling to fully kind of go down the road of just saying, I trust everybody, take the ROMTech machine home for 6 weeks, use it 5 times a day, and I'll see you in 6 weeks, because I still believe that you need monitoring. And if somebody is moving slower, the therapists reach out to us, right? They make us aware. If there's wound complications happening, right? Having more eyes on the incisions. Physical therapists have been doing this for a long time, longer than most than I've been operating, right? They know when a knee is not behaving correctly, right? They have a certain paradigm that they follow, and they know when something falls outside of that scheme. So for most people, I think physical therapy still should be done at an outpatient center once the incisions are healed, which is somewhere around 2 weeks. It typically lasts about 4 weeks. By 6 weeks, my expectation is that if you're able to get that motion, that your pain relief should be somewhere between 75 and 80% within those first 6 weeks. And what that tells me, right, that's a arbitrary number, but what that tells me is that you are able to go back to most activities, right? You still have some stiffness. There's still occasional pain, especially after a long day, but you can drive, you can begin to exercise, you can go back to playing golf, you can go back to work. And, the hope is that if we kind of utilize more of these minimally invasive techniques, that we take that endpoint from being, the expectation now for most surgeons is that 3 months that most people can go back to these activities. I'd like to move that up to 6 weeks.
Mm.
Um, and, so that's kind of still like what I consider a success story, that by 6 weeks, you have 80% improvement in your joint pain, your joint function, and then you can go back to activities.
Someone's asking about the use of nerve blocks to control post-op pain. Post-op pain. Is that
We do it during surgery because when we close every incision, we actually provide a local tissue block. In a sense, it's a local nerve block, but it's not a nerve block the way that you consider, some shoulder surgeries. They'll actually put a catheter in to the joint, and that catheter will slowly kind of drip a little bit of anesthetic fluid over the nerve in that area. And that has been shown to kind of decrease pain for a little while. But the problem with all of these kind of like tricks to the nerves is that that catheter has to come out at some point. Your body will always begin to feel the pain as if it just happened the moment that that nerve block fades. So the problem with those types of, techniques are it just kicks the can down the road a little bit. So with my cocktail, with my local kind of infiltration cocktail that I give to every patient at the end of the case, it is very unusual for a patient to have pain for probably about 24 and sometimes 36 hours after surgery.
Mm.
So in that 24-hour window, it allows you to get home. Even if you spend the night in the hospital and you go home the next morning, you can still get home and you get home safely before that block starts to wear off. A little bit, blocking like the true nerves, like with like local anesthetics or catheters. I'm just a little bit weary of for infection reasons. Any potential pathway to that knee, whether it's a catheter or an injection that kind of lingers, is potentially a source of infection. So I like to just kind of like when the incision is closed, I don't want anything else touching that incision. I don't want anything else going into the knee unless it's something that I've directed.
Um, just a couple more questions, if it's okay. Your opinion on gel shots as an interim treatment, and what effect does calcium crystals have in the knee? And I guess how do you know when it's actually time for replacement versus those shots kind of thing?
Yeah, gels are another kind of if you look at our academy, they've said that they essentially don't work. But they've also said the same thing about steroid injections. And I know full well if anybody's had a steroid injection themselves, it shuts down the pain process very, very quickly. It may not be lasting for, months and months and months and years, but it typically stops that inflammatory cascade. So with gels, I have enough patients that come back to say, well, it works for me, that it's hard for me to eliminate it based off of the data. So, in the early stages, I find that probably a gel injection is beneficial because it probably does reduce some friction. It probably does provide a little bit of what we call viscoelasticity, elasticity, which is essentially the idea of like a shock absorber. And to this day, insurance companies are still paying for it if you've done the prerequisites for it. And insurance companies are paying for it, then I feel less, guilty or ethically kind of, um, worried that if I give you the injection, it doesn't work, that, it costs you $500, $800. So insurances are still paying it. And then I tell somebody that if your insurance company is not paying it and you really have advanced osteoarthritis, I don't recommend it at that stage. But if it's somebody that has mild, potentially moderate osteoarthritis, they are clearly not looking at a knee replacement. It's not going to hurt, right? And really the question of like, when do you know you're ready for a joint replacement? This is really where the physician is important, right? It is not just how the x-ray looks. It has to do with your function, your goals, what, activity modifications that you've made, activity modifications that you're unwilling to provide because it would change your life to that degree. that it's not, that you wouldn't consider it worth, living, with a painful knee if it means that I have to not, exercise and not play sports and limit how much I'm walking. So really what I like to hear from people is that they've tried conservative treatment, that the pain seems to be unresponsive to that conservative treatment, that it's lasted not for just a couple of weeks, but it seems to be lasting for some duration of time where we know it's not just a flare, but that it's actually a more permanent, aspect of their day. So I typically tell people that, if you've had pain for the last 6 months and there's been more bad days than good days, and I find the appropriate imaging, which shows advanced osteoarthritis, then joint replacement is an option.
And I guess we were asking to, look into a crystal ball, but what do you see for the future? Like if somebody wanted to wait a couple years, would there be any changes? What would be the advantages?
If you asked me that 6 years ago,
Mhm.
I would have said nothing is going to improve. This is the best that it's been. I'm the best that I've been. I can't imagine myself being any better. And I've said that every single year since. So last year I said I could not be making my knee replacements any better. This year I'm making them better than last year. I said the implants probably aren't going to change that much. The implants are always changing, right? Because that's the drive in the industry, is that they have to create a competitive advantage. It's not always good, but oftentimes it does provide, kind of bring more markets, more products to the market. Um, Manufacturing processes are getting better. Um, like I said, the goal is that, one day, short of a vaccine for osteoarthritis, the goal is that you can do these surgeries at using such minimally invasive techniques that, these surgeries, will heal, on the order of, weeks, not months. So I always tell people, like, there's it's like when you buy a new car, you got the new model this year, but within a couple of years, that model may be, obsolete. So I think you have to really kind of look at what your goals are, how much it's affecting your life today, your age and your current health status. So if somebody's in their mid 80s, would I advise them to wait until, a couple more years before having a joint replacement? Probably not, right? They're at their most healthiest now. If somebody's in their late 40s, does it make sense to try to wait as long as they can before having a joint replacement? Of course, right? Somebody at that age, their expectations will be much higher of the joint replacement. Their use or abuse of that joint replacement would be much higher. And for them, waiting makes sense. I have this is a personal story. I had an ACL, like I mentioned, in my knee. I now have osteoarthritis in the lateral compartment of my knee. At the age of 39, am I going to be having a knee replacement? I will not. Do I think that in my 50s I will? Almost certainly. Am I hoping that that's a partial knee replacement first? Of course. But time will tell. So, until then, I do low impact exercises. I take NSAID medications when I need it. I try to modify my activities where I can. I don't perform high impact jumping types of exercises. And all of these things work. They work very well. It's just there's a clear kind of cutoff where the body's no longer able to kind of compete, and it falls off. And that's when the doctors, the orthopedists really become, critical.
Okay, just one final
Yeah.
question. Why is pickleball harder on your knees than tennis?
Um, it probably isn't, but what I think happens is tennis, I find that most people at some stage age out of tennis,
Mhm.
or at least, maybe they'll go to doubles, right? Um, And then they like to say, like, well, pickleball is way less, movement, way less, risk. I may not be able to run a full court on a tennis court, but I can run a much smaller, half-size court. But what happens is that very few of us are kind of willing to acknowledge that, like, yeah, maybe we do have some like underlying conditions in our knees. So I don't think, pickleball is causing, people to have joint replacements, but I think it's stressing them in a way that it's uncovering the underlying kind of problems. So, listen, everybody should keep playing pickleball, right? Everybody should keep playing, playing golf. But I think you just have to pay attention a little bit. And, what the data is saying is that the number one problem for United Healthcare, I remember reading the study, was not, joint replacements. It wasn't, the changes in like, insurance, climates, X, Y, and Z. It was pickleball. They said there was more claims made because of pickleball than like just about any other, issue. So, just be safe out there.
Be
It's not worth
mindful.
dying for that one point. So.
Thank you so much, Dr. Dizdarevic. It was just wonderful. So appreciative. At this time, I'd like to remind everyone at home to take a few minutes to complete the survey using the SurveyMonkey link, which can be found again towards the bottom of the email you received with the link to join this meeting. If you're interested in future Valley events, please visit www.valleyhealth.com/events for upcoming programs. Thank you again, everyone, for joining us, and have a wonderful, wonderful spring. Thanks, Doctor.
Thank you, guys. Take care.